Very excited to introduce our next speaker, Dr. Molly Brett. Dr. Brett is a general internist and primary care physician who practices at the VA. She is mother of two children, 3 and 5. She's an expert camper, and uh, she also has a particular interest in deprescribing as well as the preoperative cardiac evaluation, which she'll be speaking with us about today. Dr. Brett went to college at Yale and went to medical school at Harvard, and then she did her residency training at Beth Israel. And we're delighted to have her with us today. Dr. Brett, thank you for being with us.
All right. Thank you so much for the introduction, and thank you for having me here to talk about this topic. Like I said, I'm a general internist. I became interested in this topic in part because this is an area that I think, like many things that we general internists gravitate to, has a lot of nuances and a lot of areas of ongoing uncertainty. So that sometimes makes it a hard thing to teach about, but it does make it a fun thing to learn about as well and to do in your day-to-day practice. Um, and I just want to mention as well, I know many of us are a little bit distracted today by the election. And so bear with me, and I'll try to really kind of stop us and highlight the major changes in this talk so that you can at least come away with some, points that you can apply to your practice immediately. I have no conflicts of interest to disclose. Learning objectives for today. We're going to use the brand new ACC/AHA guidelines on this topic to assess cardiac risk and to guide rational clinical decision-making about preoperative testing. We'll describe the predictive value of functional assessment and biomarker testing when applied to evaluation of perioperative cardiac risk. And then we'll discuss recommendations about managing medications perioperatively. So as you can see, the focus of this talk is on cardiac risk assessment, because to cover sort of all sorts of preoperative evaluation topics could be an entire year of grand rounds, but we will talk about some adjacent things as well. So hot off the press, as of about a month ago, the last set of ACC/AHA guidelines on this topic that you may have been familiar with were in 2014. So 10 years later, they finally released an update. A lot is similar, but like I said, there are some new areas that you're probably not familiar with. So I will try to really hone in on a couple of those today. So to begin, I want to start by sort of zooming out about what I consider the pillars of these preoperative evaluations, some concepts that you can apply to kind of various areas of risk evaluation and perioperative management, not just kind of the focus on cardiac risk assessment, and then we'll zoom back into more detail on that. So I think we all know, even though sometimes we're asked to quote clear patients for surgery, there's much more to it than that, language that we prefer to never use in these evaluations. So I think of first, one of the reasons I like these visits is it gives me a chance to optimize any pre-existing conditions that the patient has. So do they have CHF and they're not sort of already on the proper or the recommended GDMT for some reason? Do they have COPD and their inhaler regimen is out of date? Anything like that is probably the most helpful thing that you can do to manage risk perioperatively for your patient. So taking a step back, looking at them holistically, it gives you a chance to kind of have, the kind of almost like an annual visit that we all would like, where we can focus on pre-existing issues that the patient is having. I also want to mention here, even though it's not the focus of this talk, this is a really great time as well to think about tobacco use disorder, alcohol use disorder, and see what we can do to help a patient with those issues as well. Next, and the area that we will focus in on, so I'm not going to talk too much about it here, is how do we assess the patient's risk? Now, we assess the risk not only to kind of sign off on these, quote, preoperative visits, but for so many other reasons. So we want to have a frank conversation with the patient, if this is an elective surgery, about what their risk might be and give them the chance to think that through. We want the surgeon and anesthesiologist to be aware. And then one that I like to mention here that often comes of my risk assessments is I want to make sure that the venue for surgery is proper. So being a VA doctor, a lot of my patients wind up having surgery outside of the VA. And those places may not be fully aware of my patient's comorbidities. So one of the most common things I recommend is actually moving a patient from surgery at an ambulatory surgical center to a hospital-based setting if the patient is a complicated one. So we're going to hone in much more on that topic. And then lastly, a thorough review of the patient's medications, as well as, some recommendations about what to hold, what to continue. And if there's anything that can be deprescribed, this is a great time to do that as well. So for any pre-op evaluation, I think if you're covering these three areas, you're doing great. Now to sort of focus in on risk assessment, and specifically for the purposes of this talk, cardiac risk assessment, a couple of areas to think about. First of all, is we want to make sure that this patient is actually asymptomatic. If the patient has any active, even subtle cardiac symptoms or signs, then this should take you down a totally different direction, sort of the same way that we would evaluate and manage those patients in any primary care visit. You want to work that up. So you don't want someone going into surgery who's having what sounds like angina if they haven't had sort of the proper evaluation for that, for example. Similarly, if you're doing a good physical exam and you hear a new murmur, you're going to want to work that up, find out what that murmur is from before pursuing surgery. But assuming that the patient is asymptomatic, this is actually where it gets the most nuanced because it's not what we do day in and day out. Then you can sort of move on to, with a heavy dose of common sense as well, using this ACC-AHA algorithm that has now been updated to help guide your risk assessment. So that's what we'll, sort of delve into from here. We're going to walk through a case throughout this to kind of keep us in line with how an actual patient might proceed through this evaluation. So this is the patient I saw at the VA a couple months ago, 77-year-old man with a history of a stroke from carotid stenosis. He had a subsequent CEA. He has insulin-dependent diabetes, last A1C of 7.4, coming in to see me for an evaluation before elective total knee arthroplasty. So first of all, like I said, I would make sure that the patient is asymptomatic, that he's not having any undiagnosed symptoms of heart failure, symptoms of angina, things like that. But then proceeding, I'm going to ask him kind of about his day-to-day life. And despite knee pain, he's able to exercise at a moderate effort on a recumbent bike, do housework and yard work. He has no cardiopulmonary symptoms while exercising. His medications are sort of as you would expect for his set of comorbidities. We'll come back to those. His exam was unremarkable. His baseline creatinine was 1.6. So where do we go from here? I mentioned this algorithm. I don't expect you to take in any of this right now. It's just to sort of show you zoomed out that there's sort of a lot of steps to potentially go through in evaluating this. We are going to walk through them one by one. Now, the risk assessment here is for patients who have existing cardiovascular disease or risk factors, and they define risk factors pretty broadly. Any woman over age 65, any man over age 55, in addition to the risk factors that we would commonly think about, smoking, hypertension, obesity, all of those things. So I say that to point out that if you get a healthy 40-year-old person coming in with, no symptoms, no comorbidities, you do not need to go down this road, okay? That is a healthy patient, no formal preoperative risk assessment is usually recommended. But a patient with risk factors or disease, it is recommended that we kind of pause and really think through a more formal assessment of their risk. One other caveat to this is not for emergent surgery, obviously. If a surgery is an emergency, you're going to go ahead with that surgery. And if the patient, is having active cardiac symptoms, you're going to go ahead and work those up. So just to reiterate, this is for patients with cardiac disease or risk factors undergoing, an elective or even sometimes in more urgent surgery who do not have active symptoms. Okay. So where do we start with this? We start with a risk calculator to get a sense of the patient's risk of cardiac events. Now, this is actually probably the only area that I was taught about in residency when it came to preoperative evaluation. So it's possible that this is the area that you're already most familiar with, doing one of these risk calculators and kind of putting that into your evaluation to give some kind of a more quantitative assessment of their risk. We're going to briefly talk about a couple of the most commonly used ones, just because I like to point out a few kind of pearls and caveats about them. But the ACC-AHA in this new set of guidelines basically says there's not great data to recommend one versus the other. And so really picking whichever one you're most comfortable with is generally okay. So the one that I think is the oldest risk calculator here, it's actually was initially described in the 70s, is the RCRI, or Revised Cardiac Risk Index. They described 6 independent predictors of perioperative cardiac complications, which you can see here includes high-risk surgery. You get a point for that. Each of these gives you 1 point out of 6. history of ischemic heart disease, history of CHF, history of a stroke, diabetes on insulin, and an elevated pre-op creatinine of over 2. They looked here at outcomes that were a little broader, so not just MI, but also cardiac arrest, VFib, pulmonary edema, complete heart block. So all outcomes that I would argue we would consider very important and want to be able to predict for our patients perioperatively. So the RCRI is very simple. It's very straightforward. It does not have any real subjectivity to the questions, as you can see. They're sort of pretty easy to say yes or no to. One element that is a downside to this is that it doesn't have any downgrading of risk if somebody is coming in for a very low risk procedure. So low risk procedures, cataract surgery obviously is the classic, but no formal risk evaluation is really recommended for patients undergoing cataract surgery because that is so low risk. But things like simple like lumpectomy, most bariatric surgeries, things like that are really known to be very low risk. And so it's possible that the RCRI may overestimate risk for low risk ambulatory procedures. So that is an important caveat to the RCRI. In comparison, the other kind of most brief risk index is called the NSQIP-MICA, or also called the Gupta score, named after the person that came up with it. This one has 5 independent predictors of cardiac complications, and I'm going to just take you through them. So age, pretty straightforward. Functional status, and they give you the choices of independent, partially dependent, or totally dependent. Now, something to point out here is that I actually had to go back to all of the initial research on this to even figure out what specifically they meant. And the best I can come up with is I think they mean when it comes to performing ADLs. Do you do them all by yourself? Do you need help with some of them, or do you need help with all of them? But your average person going to do this on MD Calc, there's really not information about what functional status means. So I think of this as a bit subjective. Next is the ASA class. That's that anesthesiology classification, which kind of goes through severe comorbidities. Is it severe that's a constant threat to life? It has sort of its own numerical classes. And again, a pretty subjective measure of a patient's overall comorbidities. They've done studies on ASA class that actually showed that if you kind of present the same case to a bunch of anesthesiologists who are trained in doing this, you're still going to get very different answers about their ASA class. So 2 pretty subjective elements to this one. Next is creatinine more than 1.5. And then finally, type of procedure. It gives you a drop-down list. And so one benefit to this score is that for a low-risk procedure, the risk estimate is going to be downgraded if that's the procedure that you choose. So just to summarize, generally become familiar with at least one of these. The RCRI is very objective, but it does overestimate risk in low-risk procedures. The Gupta score, if you're really familiar with it and using it day in and day out, it's probably fine, but there are 2 pretty subjective elements to it, which I see as the downside. So personally, for the most part, unless it's a super low risk procedure, I use the RCRI because it's the one that I'm most familiar with. So our patient, back to him, he's at elevated risk. That's the terminology that is sort of typically used for these patients who have an RCRI of greater than 1. So his RCRI was 2 for his stroke and insulin-dependent diabetes. The convention is any RCRI of greater than 1 is considered elevated risk. And then on any other score, anything above 1% is typically considered elevated risk. So his Gupta score was 1.4% risk. So on both, he falls into that risk category. The percentages are a little bit hard to interpret because these have been validated in a number of different patient populations with different different decades, different ways of assessing the outcome. And so I think if you're going to remember about anything about this, remember that the RCRI of greater than 1, or on the other indices, a percentage greater than 1% would classify a patient as elevated risk according to the ACC-AHA. So where do we go from here? Now we know our patient's at elevated risk. We've done his risk calculator. Let's say he was at low risk because RCRI was less than 1, for example, or was 1 or lower, for example. Great. Proceed to surgery. It kind of gives you an out at that point. An elevated risk patient, the next step is going to be assessing his functional capacity, which is an area of change in this set of guidelines. So we're about to delve in depth to that. But I did want to point out that one other new area in this set of guidelines is to just take a pause and look and see if they have any major risk modifiers that are not captured by those two, or by the risk calculators that are commonly used. So things like severe valvular disease, a stroke within the last 3 months, pulmonary hypertension, those are all missed in those risk calculators, as you saw. And those are areas where they would say, okay, instead of proceeding down the algorithm, you should probably have a conversation with a couple of, with the patient subspecialists in decision making about whether to proceed with surgery, and whether any additional optimization is needed first. So that's sort of a little bit of an offshoot here before you proceed with the rest of the algorithm. And that's new. Okay, so functional capacity for our patient. So we're going to kind of go ahead and talk about different ways to assess functional capacity. But like I said, this is an area that has changed a bit. So most of you are probably familiar mostly with the METS assessment as an informal way of assessing a patient's sort of functional status, what they can do on a day-to-day basis. And there you ask yourself, or you could ask the patient with your, in the office, can you climb up a flight of stairs, walk up a hill, walk on level ground at 4 miles an hour? That's the threshold that's typically used. If no, that's less than 4 METs, and you would consider that concerning. If yes, that's greater than or equal to 4 METs. And historically, that's sort of been a stamp of approval. Okay, this patient should be reassuring me about their overall risk. We're going to talk about some, why we're moving away from this. Now, the Duke Activity Status Index, you can see here, it's a 12 question questionnaire that is a lot more specific about what the patient can and can't do. And I'm not sure if any of you guys have used this before. It's called the DASI score, colloquially. It's out of 50.2 points. And the higher you get, the better your functional status is. So you can see, like, can you run a short distance? Can you do heavy work around the house? And they give examples. Can you do yard work? Things like that. Now, why am I talking about this new and obviously more time-consuming questionnaire instead of the classic METS assessment? Here's why. So since the last set of guidelines, a big study came out in the Lancet called the METS study that really looked at how much does this matter? Do these assessments actually predict perioperative cardiac events? And unfortunately, they found that doing that subjective METS assessment that we talked about does not actually predict the patient's metabolic performance on exercise testing, nor did it predict death or MI after surgery. So all of what we kind of had learned about this was somewhat disproven by this study. Now, that doesn't mean that a METS of 10 is not reassuring, but sort of using that threshold of 4 that we've all been taught really didn't consistently predict perioperative cardiac outcomes, unfortunately. The Duke Activity Status Index, on the other hand, in the same study, lower scores did predict death or MI after surgery. And the threshold here, scores less than or equal to 34, as you decreased by each point, the odds ratio for a perioperative event went up by about 1.05. And so that's additive. So lower than 34, every point lower that you get sort of an increased stepwise risk of bad events related to their surgery. As you go up from 34, you see better outcomes with surgery. And so this has been suggested now by the ACC-AHA as what we should be using for this very important part of the patient's perioperative risk assessment. I started doing this, about a year and a half ago when I started really going in depth into this topic. And it does take a little time. It'd be great if it's something where you can kind of hand it to the patient to do before your visit, then it'll go much more smoothly. But it doesn't take that much more time. I'd say a couple more minutes because those questions are pretty straightforward. So I kind of now clarified here, they recommend primarily calculating the DASI score, Duke Activity Status Index, as the next step as your way of doing a functional assessment. And you get 2 options here. If the patient has good functional status, you can see the cutoffs. They would say, okay, proceed to surgery. That's very reassuring. That's almost like the patient kind of undergoing stress testing on their own. If the patient has poor or unknown functional status, that's where things get a little complicated and where another very new element to this, to these guidelines that I want you to be familiar with comes up. Whoops. So So let's actually turn back to our case and think about, this is actually the real patient I saw. Same exact comorbidities, but his functional status was severely limited by knee pain. He couldn't walk up his stairs. So his Duke Activity Status Index score was about 19. So what do we do for him? We know just kind of on the gestalt based on his comorbidities that he's at elevated risk as well as by the risk calculator. So we're a little worried about him. What they would recommend, and like I said, this is new, would be measuring a BNP or an NT proBNP, whichever your lab has to offer. We at the VA use the proBNP. If the testing might change management. So if this is not an urgent case where the patient may be interested in doing some additional cardiac evaluation, you can use the NT-proBNP or BNP as another way of honing your risk assessment in these patients who have poor unknown functional status, where you're sort of left just saying, I just don't really feel confident this patient's going to do okay with surgery. So why is this part of these new guidelines? Here's why. This is just one of a number of studies that have come out in the last 5 years or so about the use of a pre-op BNP as a predictor of perioperative cardiovascular risk. So this is just one of the studies, like I said, this looked at 30-day perioperative cardiac outcomes stratified by their preoperative BNP. And again, this was in patients at elevated risk, but asymptomatic. So these were not patients who were having active angina, heart failure symptoms, things like that. And as you can see, so looking across the top, each column is a different BNP category, essentially. And as the BNP rises, you see the hazard ratio for all-cause mortality, or MI, increase sequentially. So by the time you're getting up to a BNP of over 1,500, the hazard ratio has gone up to 5.34, and below, the incidence of those events has gone up to 15.3. But even with the lower numbers, so 100 to 200, and then getting above 200, you really still see a pretty significant increase in the incidence of these events. I will mention, having looked at this study, most of that incidence is accounted for by MI and not mortality. I think, maybe 1 to 2% in that highest risk category was mortality, but most of it is myocardial infarction, not mortality. Okay. And so this is just one of a number of studies on this topic. This same study found that adding a BNP to the patient's RCRI score reclassified about 25% of patients, which is very interesting. Now, there hasn't been full consensus on that. Some studies have sort of shown like it's a little bit less helpful, but this is the study that's kind of most cited, and the ACC AHA really goes to incorporate this as a new part of our guidelines. So where do we go with this? So they say if the patient's BNP is normal, and you can see the cutoffs here depending on what your lab uses, go ahead, proceed to surgery. That's reassuring. You saw that lowest risk category, for example, the incidence of those events was, I think it was 1.7%, so pretty low. If the BNP is abnormal, then we're left with not really being sure what to do, to be honest. And so what they say is, and we're going to delve into this more, is you would consider some multidisciplinary discussion, and you would consider further testing like a stress test or a coronary CTA. I do see there's some things coming in the chat, and I promise I'm going to answer questions toward the end. I can't monitor both at the same time. So I just want to acknowledge some of you I know are asking some questions, and I'm going to definitely address those. So definitely keep them coming. So multidisciplinary discussion. I'd love to hear from those of you who practice the university. Is there a formal method for that? There at the VA, what multidisciplinary discussion really means is me on Teams kind of frantically sending a bunch of messages to the patient's cardiologist, to an anesthesia person, the surgeon sometimes, and trying to get us all together to think about what makes sense. But a lot of this really falls on us as the generalist to decide whether, with the patient's input, whether any additional testing is warranted. And so I want to talk a little bit more about the evidence for doing stress testing before surgery, and whether or not that has been shown to be beneficial. So to do that, we need to think about what are the possible outcomes that could come from a, quote, positive stress test. And there's not that many. So in the perioperative setting, you could do revascularization, medical therapy, or reconsideration of surgery if the patient appears to be at extremely high risk. So what are the data for at least those top two items, revascularization, medical therapy? Do doing those things before surgery actually help outcomes? So what do we know about that? Here's what we know about revascularization. Most of the research on this comes from the CARP trial, which was a study in 2004, looking about 500 VA patients who are undergoing elective vascular surgery. So I highlight vascular surgery because that is a high-risk surgery. They all had known cardiac risk factors. I mean, these patients were pretty sick. They remind me of my own patient population. 40% had prior MIs, half were smokers. A substantial proportion had had a prior CABG even. And what they did was they put all of these patients through a cath to see if they had any significant coronary artery disease. And the patients with significant CAD were randomized to either revascularization or medical treatment. So aspirin and statin. Of note, patients with unstable angina or left main disease were excluded, but 30% of these patients actually did have three vessel disease. So again, these were really sick patients with significant CAD. And here's what they found. Among patients with stable coronary disease, revascularization before elective surgery did not improve survival. So if you look at the survival curves here, you can see that pretty much they line up. The area, that first year after randomization, the patients that appear here to do worse were actually the ones that underwent revascularization, not the ones that went into surgery with untreated, at least unrevascularized, significant CAD. So this study, really, I think is an amazing one in showing that, sort of as we had learned previously from the COURAGE trial and other studies in the non-perioperative setting, revascularization of stable coronary disease really doesn't seem to improve outcomes. Now, a caveat to this that a lot of cardiologists that I've talked to when I've been really diving in depth into this topic is that, like I said, left main disease was excluded. And so we'll talk a little bit more about how that sort of still makes some people a bit nervous. But I think this is a really important study to remember and has really affected management. So revascularization, is that beneficial for patients undergoing surgery? At least for the CARP population, there was no benefit. And then another important caveat to this is that if a stent is placed, you really need to delay surgery for 6 to 12 months, depending on the PCI that's undergone. And for a lot of patients, that's unacceptable. But how about medical therapy? So should we be stressing people so that we're getting them on the proper medical therapy? Will that improve their perioperative outcomes? Unfortunately, the answer to this is also probably not really. What do we start patients on after a quote positive stress test? We start them on aspirin, and there's more to come on this in this talk, but the most benefit for aspirin is actually the only really clear benefit that's been shown is after someone gets a stent. And so without stenting, it's pretty unclear whether putting these patients on aspirin will benefit them perioperatively. In terms of, and again, these are asymptomatic patients. Statin, to be honest, the studies on this have also sort of been conflicting, but most of us agree, okay, there's probably some benefit to putting somebody on a statin before surgery who kind of already should have been on a statin. Most of the time, if you're getting this far down into the algorithm and thinking about stressing a patient, they're going to already be on a statin. And then beta blockers, should we be starting beta blockers preoperatively after a stress test? So the biggest study on this, the POISE trial, started beta blockers in the immediate preoperative period, and it showed that starting a beta blocker right before surgery increased hypotension and stroke risk. That was within about 7 days of surgery, and there's really not very consistent evidence to show that starting a beta blocker earlier than that would benefit a patient either. There's been a few studies to either direction, but the consensus is we shouldn't really be starting beta blockers preoperatively for the purpose of improving perioperative outcomes. So again, medical therapy to come after a stress test, not really super helpful either. So actually, the only time that I find this pretty helpful is reconsidering surgery if the patient's not sure they want to do it, and if a stress test that looks concerning would lead them away from surgery. So what do the new guidelines say about this? How do they interpret all of that evidence? So in there, kind of, if you're going to look at anything in these guidelines, they have a list of about 10 kind of key points before you delve into the rest of the 100-page document that I read most of. And they say there in the key points, Stress testing should be performed judiciously and only in patients in whom testing would be appropriate, independent of planned surgery. And that is a very clear statement against stress testing just for the purpose of improving perioperative risk based on all of the data we just talked about. Now, like I said, cardiologists do still get very nervous about the exclusion of left main disease from that big study. And so they sort of contradict themselves later in the guidelines. And they say the goal of preoperative testing for ischemia is not to identify undiagnosed CAD, because again, that's not been shown to be beneficial, but to identify patients for whom revascularization, quote, is believed to improve clinical outcomes, specifically those with left main disease or severe multivessel disease with a reduced LVEF. So this is still an area of tension. I've talked to a number of different cardiologists about this. They all sort of agree that their anxiety around not testing patients before surgery is that undiagnosed, left main disease specifically. But none of them can really give guidance on when do we even suspect patients who have left main disease in the absence of symptoms. So again, clearly if someone's symptomatic, you're going to go ahead and proceed with some sort of testing. But in an asymptomatic patient, this tension remains, and we really don't know clearly what to do with these patients. So for the most part, having looked at all the research myself, I think kind of going primarily off of that top box, that blue box take-home point about really only thinking of stress testing if you would already be considering it independent of planned surgery is really where the research falls on this. So it's a hard thing to put on us as primary care doctors, but I think kind of remembering that take-home point really helps. So again, we've kind of proceeded for our patient through this path. And if his DASI score was low, if his BNP was high, then we would think about that additional testing. Now, they mention also coronary CTA as a possibility, not just stress testing. That's not something I have a lot of personal expertise with because we don't order them very frequently at the VA. But there is, I think a lot of cardiologists are increasingly interested in the use of coronary CT rather than stress testing for the small subset of patients who've kind of gotten this far down the algorithm, because it does show if somebody has left main disease. The caveat to that is it tends to vastly overcall other coronary disease, which may or may not be physiologically significant. And so that is a real downside potentially to doing CTA, but that's still evolving. And I think it's probably going to replace stress testing for this purpose down the road. So just as a reminder, luckily we do now the BNP here, even though, if it's abnormal, we still kind of not really sure exactly what to do. If it's normal, it gives us sort of a second chance for an out where we can say, okay, you can proceed to surgery. So I do like that this was added there as sort of another branch point to help us feel more confident about sending our patients to surgery. So how about our patient? He's an elevated risk patient. He has poor functional status. And I talked to him. I said, because I was already aware that this was probably going to be in the new guidelines when I saw this patient, we talked about whether or not to check more labs and then consider stress testing. But that would have led to, again, either revascularization or medical therapy. When it came to revascularization, he said he wanted to proceed with surgery for that really painful knee as soon as possible. And we talked about it was kind of unclear if there would be any benefit. And then for medical therapy, this guy was already on an aspirin and a statin, which, many of the patients that are at this point are already on. And he didn't want to reconsider surgery if things looked concerning. So he actually decided to proceed with surgery. We did not check a BNP in him. And in this high risk or elevated risk patient, a 12-lead EKG to have a baseline was the only preoperative testing that was performed. And that really is in line with those guidelines. Okay, I'm going to pause here and take a quick look at the questions. I think this may be a good time to answer some of those questions. Okay, so somebody asked, what do they consider a short distance for running? That is a really good question. I think you were referring to the DASI score, and they don't specify actually. So what I ask is, could you run for, for any period of time, basically? But they don't, you're right. That's still an area sort of where there's some subjectivity. And she said, yes, we're in Colorado, so short, long run is a very different standard. Yeah, so I think if my patient can run at all, I'm actually sort of impressed. Next, another question, is there any discussion of a different BNP cutoff for increasing BMI? Great question. We know that the BNP is not as reliable in patients with higher BMI. That has not, to my knowledge, been studied, but I think it's a really important caveat for patients, if you're seeing patients with obesity, that it could be falsely low and falsely reassuring. Somebody said, it sounds like practically speaking, there isn't much to be gained for a multidisciplinary discussion, really just a shared decision-making discussion with the patient. I completely agree. I think once we all, as generalists, are familiar with these data, then we can feel comfortable having shared decision-making with the patient. I think that, if this is something that you don't do frequently with really high-risk patients, I understand the role potentially for at least kind of wanting reassurance from a cardiologist. But for the most part, I feel comfortable, knowing my own pretty much all elevated risk patients in having these conversations. Somebody else asked, is there any differentiation of risk between different types of anesthesia? So yes, definitely. And part of why the type of procedure is an important part of those risk calculators is that, general anesthesia, obviously higher risk. The duration of surgery is a major risk factor that or a major predictor of cardiac and actually pulmonary risk as well. And so for a really long surgery, you're going to want to take these evaluations very seriously. The risk calculators sort of incorporate that, especially the Gupta score, by having you pick what type of surgery the patient is having. And so generally the higher risk surgeries are ones with a longer duration of anesthesia. Somebody else asked, these are great questions. Some cases we receive from the surgeons a list of tests they want for pre-op, many times excessive. Do we refuse and risk the patient not getting the surgery? That is a really hard question. And I will be honest, it depends on how I am doing that day, how deeply I want to argue. I can say that seems to, I've been practicing for 5, 6 years now, so not that long, but that seems to have decreased in my time of practice. In terms of people wanting a urinalysis, a chest x-ray, all of those things. If it's a surgeon that I am able to talk to directly, I will sometimes push back on that. But if it's going to mean that the patient doesn't get a surgery that they really want to have, oftentimes I'll go ahead and do it. Awesome. All right. Thank you, guys. Those are great questions, and please keep them coming. I am going to go back to talk a little bit more about medication management now. All right, so taking a look at this patient's medications, how do we manage his cardiac meds as well as some of his related medications? So ACEs and ARBs are sort of a hot topic right now in the peri-op medicine world on whether or not we hold them or continue them perioperatively. Many of you guys are probably familiar with sort of the older guidance that says these risk intraoperative hypotension, we should stop them in everybody preoperatively. There was a study that came out actually just a few months ago that tried to answer this question. And basically, they randomized patients who were already on these medications to either continuing them or stopping them before non-cardiac surgery. And what they found was that the overall outcomes in terms of morbidity, mortality, cardiac events, all of that was the same no matter whether you continued the medication or held it. And so this is already seeming to influence practice, and it also influenced these new set of guidelines. Now, they did find in that study that there was more brief episodes of intraoperative hypotension, as you would expect, in patients taking these medications. That said, it was managed appropriately by the anesthesiologist, maybe a little more rapidly, considering that these were patients in a study, but the overall outcomes were the same. So here's what the new guidelines say to do, which really makes sense to me as well. For patients with well-controlled hypertension, so kind of baseline, low normal or normal blood pressures on their meds, it's probably okay to hold these. Now, if stopping the medication if in your clinical estimation, their blood pressure is going to go above 180 over 110 off of these medications, which is true of a lot of my patients, then they say, continue it. The patient should be fine. I usually will let the anesthesiologist know that that was the recommendation that I'm making, and I haven't gotten pushback on that, especially since that new study came out. And then lastly, in patients that are taking RAS inhibition for heart failure, really there's not been much research to show one way or the other. So the ACC-AHA says we recommend essentially continuing all GDMT for heart failure, including, if they're on something like Entresto, go ahead and continue that. Don't hold that the morning of surgery. Okay, so this is a little bit new, and I think very helpful for those of us who have a lot of patients with difficult to control hypertension. How about the SGLT2 inhibitor? So this is one that we see very often. This is now recommended formally to be discontinued 3 to 4 days before surgery to reduce the risk of perioperative metabolic acidosis. This is actually one of the few things in the guidelines that has like the highest class of recommendation, even though the evidence for it is more anecdotal and case studies. It's not going to be harmful for the most part to the patient to stop this 3 to 4 days before surgery. But we do see increased risk of DKA after surgery if the patient continues these medications. So that's when we need to absolutely inform your patient that, you're not just holding meds the morning of surgery. These linger, you want to stop it 3 to 4 days before. And this is an exception to what I had mentioned about the GDMT for heart failure as well. You do want to stop this medication. So hopefully you're seeing the patient early enough before surgery to make that recommendation. How about semaglutide? So my patient was on semaglutide. How about injectable GLP-1 agonists in general? Obviously, we're seeing a lot more of these. Now, for this, there's been a lot of buzz around, it slows digestion. There's a risk of retained gastric contents. And does that actually lead to increased aspiration risk and more negative perioperative outcomes? So because of that concern, the ASA and now also the ACC-AHA suggest holding those injectables a full week prior to surgery. So basically just skipping whatever dose they would be taking within the week before surgery. The evidence on this, just so you guys know, is a little bit conflicting. So anesthesiologists super nervous about having patients on these medications, understandably. But there was another study that came out, honestly, just a week or two ago that basically showed while there is a higher rate of retained gastric contents, it's not clear that that actually leads to an increased aspiration risk. That said, this is a medication where really you do not expect any negative outcomes for holding this at least a week before surgery. And so I would go ahead and tell my patient to stop it. Sometimes because I don't always see my patients far enough in advance of surgery, if I know they have a surgery coming up, I'll make sure to give them a call so that they skip that dose because they are at very high risk of showing up the morning of the procedure and the anesthesiologist turning them away if they've taken this medication. Okay, statins. At least we have a nice simple one here. Continue. There's really no harm in continuing a statin. There may be some slight benefit. And then if the patient really kind of should have been on a statin already, we would say go ahead and initiate that in the preoperative setting. And it does not matter how close to surgery, even if it's a day or two before, you can go ahead and initiate the statin if it's recommended for that individual patient aside from surgery for long-term use. So go ahead and start a statin if that's something kind of missing from their overall medical optimization. And then lastly, aspirin. This is the last topic that we're going to really dive into in detail, but I do want to talk a little bit more about aspirin because I think it's one that we face pretty frequently as a question to us, the generalist. The kind of bulk of the data on perioperative aspirin comes from the POISE-2 trial from 2014, which randomized about 10,000 patients, 30% who did have prior vascular disease and all of whom had cardiac risk factors, to aspirin 200 milligrams or placebo before non-cardiac surgery. And then they continued it for 30 days thereafter. Now that 200 milligram thing might look weird, but it was basically Bayer trying to come up with a way to get aspirin back on patent. So you see a lot of weird aspirin dosing in any more modern trials of aspirin. Okay, so here's what they found. So again, these were relatively high-risk patients. And what they found was that aspirin did not decrease rates of perioperative death or myocardial infarction. As expected, it did increase major bleeding, relatively small amount, but it did. And the only subgroup of patients that seemed to benefit from aspirin were the patients who had a stent, a cardiac stent. Those patients had a pretty substantial decreased absolute risk reduction here, 5.5%, taking aspirin before surgery. So stented patients, yes, benefit. Patients taking this for primary or secondary prevention did not actually have a benefit from taking aspirin before surgery. Now, this is just one of the studies on this. Really, there has not been any robust data to show that aspirin does benefit, but I will say there's at least a theoretical concern with stopping aspirin before surgery about a slight rebound in events. And so that gets everybody a little bit nervous, stopping aspirin. And that is one of the kind of caveats to this. And I'll kind of talk about how we incorporate these data, but also that element into the guidelines on this. So here's how to think about the aspirin. If a patient's on aspirin for primary prevention, discontinue it, probably permanently, based on those 2018 trials that really didn't show benefit for most patients with with primary prevention aspirin. If the patient's on it for secondary prevention, because of that kind of anxiety about a rebound in cardiac events after stopping it, you can weigh the patient's surgical bleeding risk with the patient's cardiac risk. So how I think about that is if the surgeon is not at all worried about me continuing the aspirin for a patient who's on it for secondary prevention, I usually say, okay, let's continue it. Now, most of the pre-ops that I wind up doing at the VA are for orthopedic procedures or urologic procedures. For orthopedic procedures, aspirin is actually being used, in a lot more patients as thromboprophylaxis. So for the most part, orthopedic surgeons say, sure, continue this medication. For the urologic procedures, my husband is a urologist actually, and so I've asked him about this, and it does not make him, for the most part, worried either to have a patient continuing aspirin. So for my high risk, secondary prevention patients, I'll often continue it. I would definitely stop it if the surgeon said, this is an extremely high bleeding risk case, I prefer that you stop it. So that's how I think about that area of nuance. If the patient has a stent, nice clear guideline here, we would continue it. There was, evidence of benefit. And then lastly, so how about if you have a patient with a history of coronary artery disease who never had a stent, who's not currently taking aspirin? Should you start it? No. The answer is no. We do not recommend initiating it preoperatively. Those patients didn't benefit in that POISE trial either. Okay. So primary prevention, stop it. Secondary prevention, some nuance, weighing risks and benefits. Stented patients, continue it. All right, let me check time. Okay. In the last minute or two before I stop and take more questions, a few more pearls from the new guidelines. So one that I wanted to mention, because this question comes up often with my residents, is who needs a preoperative echocardiogram? They have a pretty limited answer to this. So those with signs or symptoms of undiagnosed CHF, or patients with known CHF and signs or symptoms of worsening status. So let's say you don't really have a good sense if the patient CHF has progressed dramatically and now there's someone who you would be thinking about an ICD and all this other stuff. So basically if a patient's having, recurrent episodes of decompensated CHF and they haven't had an echo recently, go ahead and get one. Or patients with signs or symptoms. They don't specify this element of a new murmur, but that as well is another patient where I would get a echocardiogram preoperatively, undiagnosed murmur. And then the last kind of pearl that I wanted to mention, this isn't as relevant to me as a primary care doctor, but for those of you that practice inpatient medicine, you're going to want to go take a look at this in the guidelines. They now say, considering measuring troponins in asymptomatic people 24 and 48 hours after surgery for sort of patients with known CVD or high risk. Now, why are they saying measure troponins in these asymptomatic patients post-op? The reason for that is to detect what is called myocardial infarction after non-cardiac surgery, or MINS. So many of you may be familiar with that acronym. MINS basically refers to any myocardial event after surgery, but not just people who have symptoms of an MI or not just people who have EKG changes. So MINS incorporates those two things, but also asymptomatic troponin elevations. Now, why would we care about this asymptomatic troponin elevation? This is a really increasing area of interest because patients who have high 30-day and beyond mortality, I think, some of the data really suggests that even like 10% 30-day mortality for patients that have what we call MINs. So the guidelines basically say, what do we do with that? If the patient is found to have elevated troponins, even in the absence of symptoms and EKG changes, you may want to think outpatient about doing everything you can to really aggressively manage their cardiac risk factors. But a lot more research is needed to fully understand what to do about MINs, because it's a pretty new concept. Now, that said, if a patient has EKG changes, you would manage it the same way you would any, acute ACS type of picture. So really, the troponin measuring here is to help you detect those asymptomatic patients where it's just the troponin elevation, so that outpatient, that can be noted, and as much as we can, aggressively managing their risk factors maybe will benefit them. We're not really sure yet. So that's something to delve into a little bit more if you practice inpatient medicine and take care of a lot of post-op patients. All right, so some take-home points, and I'm happy to take more questions. If you're going to remember anything, again, I want to focus on the areas that have changed. So using that DASI score to assess functional capacity instead of a subjective METS assessment, which has not been shown to accurately predict perioperative cardiac events. You could consider the use of a preoperative BNP to further risk stratify patients where their functional status is kind of insufficient to guide you. And then ordering preoperative stress tests only in very select patients. Only very select patients with active symptoms, or in those in whom you feel confident that this would change their management. So, for example, a patient who's sort of on the fence about proceeding with surgery. All right. We have a little under 10 minutes left, and I would love to take any questions or also kind of hear any input from others who, practice this sort of medicine. So one question in the chat, any thoughts on how you would assess risk for a patient who is non-ambulatory at baseline? Yeah, that's really hard. I think that would sort of fall into the case of, totally unknown functional status. Like that patient's Duke activity status index is going to be probably 1. And so in that case, the only things that we really have to go off of is the BNP could be helpful. So if you checked a BNP and it was stone cold normal, very low, you may find that reassuring. Otherwise, it is someone who, if with the shared decision making that we talked about, if the patient seems very high risk and you're worried about the one thing that we'd be missing would be left main disease, you could think about doing a stress test, or if your clinical setting allows it, a coronary CT. So I think it really depends on whether the patient would be interested in and or willing to kind of undergo all of the downstream effects that might have, including a delay in their surgery. Great question.
Dr. Brett, did the guidelines say anything about how the BNP might inform obtaining an echocardiogram? I think many of us think of the BNP as a test that helps us think about the risk of underlying heart failure. The perioperative literature is suggesting that it can predict myocardial infarction. I'm just imagining, you get a BNP and it's high, a more natural reaction rather than stress test might be echo, but it looks like the guidelines don't say a lot about when to get an echo. How do we reconcile that?
Yeah, that's a really good question. You're right. They don't really say a lot about that. And I agree with you. If this is somebody where, we have a completely non-urgent time frame for surgery, I think that, I think in an ideal world, probably what I would wind up doing if I could is a stress echo, because that's going to give you information about both things, at least to some extent. But they do in one tiny place mention that maybe you would think about an echocardiogram in that patient, but they really don't say it anywhere else. So I agree with you. That is something that's missing in this set of guidelines. And I think probably because it just hasn't been studied at all. Yeah. But yes, I think that would be, in an ideal world, that would be part of my workup too, if I found the patient had that elevated BNP.
Thanks.
Yeah. All right. How much of this does the anesthesiologist do? How much does this overlap? I think that really depends on your practice setting. So that was from one of my VA colleagues. I have not really seen the anesthesiologists at the VA doing a lot of this more formal cardiac risk assessment or recommending additional cardiac testing for the most part. So I think, at least at the VA, from what it has seemed to me, is that this really falls to us as the generalist, or if there is if there's a cardiologist involved, sometimes they wind up, weighing in more formally on this too. I would love to hear from those of you that practice at other sites, though, if the anesthesiology pre-op clinics are making these recommendations. Now, the one caveat to that is the medication management. I have noticed that, yeah, okay, yeah. Which do they advise which meds to hold morning of surgery, for example? She asked. Yes, I have noticed that a lot of anesthesiologists do make recommendations about medications, but it seems to me that sometimes pieces of this are missing. So, for example, I have not seen them make recommendations for the most part about all of the diabetes medications. I had one recently. I had one recently where they recommended holding the GLP-1. That's very relevant to anesthesiologists, but they neglected to tell the patient to stop the SGLT2. So, as someone who's really interested in this topic, I prefer to kind of be the director of these assessments because I know the patient best. All right, somebody else asked about opinion of pre-op evaluation for minor surgeries such as cataract surgery. Seems, yes. So all of the research on this would say no preoperative evaluation is warranted for the most part for cataract surgery, even in high-risk patients. The only surgeries that really fall into that category where they're able to make like a pretty clear statement on that would be cataract surgery, most dermatologic procedures, in-office type of procedures, and most dental procedures that are not requiring like true sedation. Being asked to perform a preoperative evaluation for those is basically going against the guidelines. And so that's one where I think it's actually pretty reasonable to push back. There's even there's even evidence, there's guidelines from the societies, the dental, the ophthalmologic societies that say you should not be asking for that type of evaluation. So very, very, very low risk procedures like that, you really should not have to do an evaluation because it has never been shown to be beneficial.
Molly, quick question. So first, thanks for a terrific presentation. This was really great and very practical. So I appreciate that. Is there any place to look for a list of medications that are indicated contrary? I mean, is there like a quick look? So if you wanted to, check your memory when you're actually seeing a patient, you could look them up.
I have not found a good single source for that. I think for the cardiac ones, there's a chunk of this new set of guidelines that really goes into all of that. And you can just look at the key recommendations. But I think because there's so much nuance to this, unfortunately, like, for example, holding tamsulosin before cataract surgery because of floppy iris syndrome, like things like that. There's a lot of kind of weird pieces of medication management. I actually haven't found a universally helpful source for that. Which, leads me to kind of, when I was less familiar with all of this, just in my own brain, I had sort of a template that I used that I had created that would remind me, hold this, continue this, here's the nuance for this medication and things like that.
Thanks.
I wish I had a helpful source for you. Unfortunately, I don't. Somebody else mentioned the UpToDate article. Yeah, UpToDate has a lot of great articles on this, including perioperative medication management. I find because they have about 10 different articles on pre-op evaluation and management, sometimes it can be sort of an overwhelming source to go to, but I think it is pretty much always a great place to start.
Well, we're right up on the hour. You can see some more thanks coming in through the chat. Really great talk, Molly. So thanks so much for taking the time for being with us this morning.
Thank you all for taking the time on November 5th to log in. I really appreciate it.
Thanks, Molly. That was awesome.